Good morning. Now, Mr. Connell, we have Miss Harvey-Wood.
Yes, indeed, Kathleen Harvey-Wood.
Good morning, Miss Harvey-Wood. As you understand, you're about to be asked questions by Mr. Connell, who's sitting opposite to you. But before that, I understand you're willing to make an affirmation.
Yes, I have.
Just sitting where you are, would you repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much,
Thank you.
Ms. Harvey-Wood. Now, I would anticipate that your evidence will probably take much of, if not all of the morning. We will take a break about 11:30 for coffee. But if you want to take a break at any other point, just give me an indication and we'll do that. Now, Mr. Connell.
Right, my lord. Now, Ms. Harvey-Wood, first of all, you've produced a witness statement. I take it you're content to adopt that statement as your evidence in this inquiry.
Yes, I am.
Thank you. I just want to ask you one or two general things before we turn to that witness statement, because what I will do is use it as a sort of guide to walk us through where we've reached. The witness statement was contributed to at various points in time, and that doesn't matter for our purposes. But probably the most significant point is that you've actually now retired, is that correct?
That's correct. Yes, I gave the witness statement in August 2022, and it was via Teams because of COVID. And then I retired at the end of May 2023. So I've been retired for just over a year.
Thank you. So that although the witness statement talks about we do this and we do that, that's what you were doing up until the point when you retired.
That's why I added the sentence that the statement was given in August 22, because I was talking about what we were doing while I was working, and because the statement was given while I was still at work.
Thank you. And when you retired, you were a principal clinical scientist in the microbiology department at the Queen Elizabeth Hospital.
Yes, that's correct.
I just use Queen Elizabeth as the short version of the full title. And in fact, as I understand it, you joined what is now the board way back in 1983.
Yes, that's correct.
Having set out in your statement what your history was before then. So that's some 40 years all involved in microbiology, is that correct?
That's correct. I had 40 years service in the NHS, yes.
Thank you. And am I right in understanding from your statement that much of your time in that service was focused on, and I'm using this not in a technical sense, but identifying samples that had been given to the lab for investigation and then reporting back on what the lab found. Is that correct?
Involved in processing samples in the laboratory.
I just want to ask you two general questions then. Given your experience and the length of that experience, do you feel you were well placed to determine whether either an infection or a pattern of infections were unusual?
Yes, I would say so over my years' experience, because it was the changes that I saw from being in the hospital at York Hill in the laboratory there, and then when we moved to the QH-RHC site. So there was a change, and from my experience and my work at York Hill, I could look at the difference, what I was seeing in the infections.
And again, just if we just take this generally at the moment, your line manager at the time you retired, I think, would be Dr. Peters. Is that correct?
When I actually retired, it was Dr. Bao,
Aye.
Abhijit Bao. He became clinical lead of the microbiology department. I'm not sure what year, but he took over the lead from Christine Peters. So at the time of writing my statement, August 22, Christine Peters was my line manager.
Again, just taking it generally, I think you're probably aware that the views Christine Peters formed on whether patterns were unusual and infections were unusual have been subject to some criticism and challenge by others. Can I just ask you a general question? Do you think this criticism of her is justified?
No, I don't think so.
Thank you. Now, if we could just go to your witness statement,
Okay.
just as a convenient way of working through events. I don't know whether you're following it on screen or you're following it from your own copy.
I can do both. Yeah,
Right.
I have it on the screen. Thank you.
Thank you. Thank you very much. And you notice the screen has page numbers which are electronic. So if I
Yes.
refer to a number, I'll refer to either a paragraph number or the
Okay.
electronic page number. So in the early part, you set out obviously your professional background. In paragraph 9 on page 77, you introduce the acronym, beloved are acronyms of those working in this field. This one's PCR. And
Yes.
this is a form of identification method to try to ascertain what the organism is that's being examined. Is that correct?
Yes, it's using DNA extraction to extract the DNA from the bacteria or the virus or the fungi from the patient's sample.
And in sequence, originally, most identification was done by growing bacteria on a medium of one kind or another and in conditions of one kind or another, and then examining the results.
That's correct. That's still the case. Both of these methods are used sort of in parallel with each other for different organs and different tests. So we use both assay types.
I'm right in thinking that you spent a lot of your time at York Hill before you moved to
That's correct, yes.
the Queen Elizabeth Hospital, is that correct? Yeah. And when you were at Queen Elizabeth, you were working mainly in paediatric microbiology, is that right?
Yes, I've always worked in paediatric microbiology. I was trained as a paediatric clinical scientist in microbiology, and the lab at York Hill was specifically examining paediatric samples from the hospital. When we moved to the site at QH, RHC, the microbiology departments were throughout Glasgow were centralised in the big laboratory block in the hospital grounds. And the paediatric microbiology department from York Hill moved to the laboratory at QH. I retained my paediatric responsibilities because of my experience, and I did not take on any adult work. I wanted to remain within my speciality and with my experience. So it was my remit to continue in paediatrics.
And apart from simply working in the laboratory, and again, I'm just asking this in general terms, I understand, and leave the COVID pandemic aside for the moment and the particular circumstances that pertain then, you would also go and speak to clinicians and discuss results with clinicians, is that correct?
Yes, that's correct.
And then occasionally attend IMTs or specific meetings when asked to do so.
Yes, when asked to do so, yes, I would attend.
And the point of you attending would usually, as I understand from your statement, be to pass on results or discuss and explain results.
That's correct.
Thank you. And no doubt also to give advice when issues cropped up that people thought you could help with.
Yes.
Is that something that happened quite a lot?
Yes, it did. Yes. I would also receive phone calls from the clinicians or from the junior doctors asking for advice on a result. Also, I would give advice on what other tests they could do to do further investigations to try and diagnose the infection. So you gave them interpretation of your result and then advice on what that result meant. And then you would advise on further investigations to give more clearer diagnostic information for the clinician.
Thank you. Now, can I ask you to just look at electronic 79, paragraph 20. In that paragraph, you discuss something called the pediatric samples queue.
Yes.
Just in a couple of sentences, what are we talking about there?
Well, in our laboratory system, we have a computer system called Telepath, and the reports are electronically put onto the computer system from the work done on the bench level, looking and examining the sample. And when the results are available, the report is put onto an electronic queue where it can be checked and reviewed and then authorised by the clinical team who are doing the authorising. Because the paediatric laboratory moved to the hospital QH, we wanted to retain some of our paediatric speciality. And at one point we wanted to have a separate section in the lab for paediatrics, but it was felt that with due process that they wanted to put everything together and centralise the whole microbiology service. But we were able to retain our paediatric reporting system and paediatric queue. So when samples are analysed, results available, the report goes to what we call our reporting queues. And there's different queues with different numbers for different types of samples and different levels of authorisation. So the laboratory Telepath system could sieve out all reports from paediatric patients from the Children's Hospital to go on to a certain queue. There was another queue for urine samples, another queue for blood culture results, a queue for adult sample results. So the paediatric samples were put on a queue called the paediatric queue.
And so somebody examines a sample, records what's found. It's then put into this queue. What happens to it? Because presumably it then moves.
Well, some of the sample results are authorised at what we call at the bench level. People work, the biomedical scientists working on the sample at a certain level can put the report together and just press sort of like go, if you know what I mean. And then the report then goes electronically into the patient notes in the clinical portal electronic reporting system where you see all the patient's results. Other level of results will then electronically go to this queue, and you log in and you see all the lab numbers and all the results, and you go into the screen and you check it. And then if you're happy with the result, then you press authorise, and that is electronically sent to the clinical portal. Your name is on that report, so it's very important if you check a report and you examine it, the results are you're happy with them, your name is on clinical portal. I don't, have you seen access to clinical portal results?
I don't believe we have, but if you, am I understanding correctly that essentially what's in the queue are things that need authorised?
Yes.
And then the person who checks them and authorises them records that that's been done and
Yes.
puts their name on it in effect.
Yes, exactly. Because when you log in, yes, you have your name, you log in with your name and your password, the computer system knows it's you. So when you press, yes, accept, authorise, your name then goes electronically with the date and the time of authorisation onto the patient's electronic records in what we call our clinical reporting system. And it's very fast. The minute you press accept and it goes through the system, it's available electronically for the clinician to see.
And they then know who has looked at it.
Yes, exactly.
Because the name appears on it.
They know the name, so they can, if they have a question, they know who reported it, then they can contact the microbiology and ask to speak to that person, depending on the level of the inquiry. And I did say that there's different levels of queuing later in my statement, depending on the level of authorization. So it's your responsibility, if you authorize a report, to make sure you're happy with it and the report is correct.
Thank you. Now, in your statement, you talk about the changing staffing levels with the move and so on. And then you go on to talk about some of the practical issues that arose when you were moving from York Hill to the new laboratory. Some comment about spending half your time in a car going from one place to another.
Indeed, I was for 3 years. Yes, absolutely.
Trying to do your job.
Yes, my mobile phone went off in the Clyde Tunnel a few times.
So, but when, I think you told me a minute or two ago, when you got into the new hospital, you still retained this pediatric speciality that you'd been with for a long time.
Yes.
We heard, I think, from a witness yesterday that the pediatric microbiology issues can be different in children because they can get slightly different infections or they can affect them in different ways. Is that your experience?
Yes, that's correct.
Yeah. If we go to 83, electronic, paragraph 43, it just to try and follow this through, in the clinical role that you had, you record here you had responsibility for 2A and 2B, which we know from other evidence moved to 6A and 4B. You also helped with the renal team in 3C at the Children's Hospital and also for the pediatric intensive care unit and the neonatal intensive care unit. And also on top of that, the burns team. These were the areas that you were particularly concerned with. And you mention in that paragraph the relationship you built up with clinicians. I think you say on the top of page 84 that you thought you had a good relationship with clinicians. Is that right?
Yes, I think I did. Yes, I'm sure they would support that comment. Yes, we did work very well, and some of them, because I've been working for so long within the microbiology department, some of the medical staff were junior medical staff at some point, and as they advanced in their career to become consultants, I had known them throughout their career and their training, and sometimes some of the doctors would come to the laboratory and ask to see around and have a visit, or would have an ID junior doctor or a trainee for their specialist exams would come to the lab and spend time in the lab. So we had a very good relationship with the clinicians, and this happened at York Hill as well as we continued that when we moved to RHC.
You go on to talk about working with the infection control team, but you're not an infection control doctor as such. That wasn't your function, is that right?
Yes.
You provided information to the team. Is that your role?
Yes, that's my role.
But do you also get involved in issues over, for instance, antibiotic recommendations? You know, what treatment should be given for a particular infection?
Yes, I do.
And you also, I think you set out in your statement, liaise with what are called reference laboratories, which we've heard a little bit about, which are essentially specialist locations where particular types of testing tend to be done. Is that correct?
That's correct, yes.
That's another thing that you did. Okay. So in York Hill, we've heard already that there was a pediatric lab just doing pediatric work, but you managed to retain specialism in pediatrics when you moved to the new hospital, although the lab itself became more general.
That's
Is that the way it
correct,
worked?
yes.
If we go to page 88, paragraph 60, reading this paragraph short, have you got that one?
Yep.
Um,
Yes.
I suppose the question that I want to ask you is that when you talk about what you saw as a reduction in available staff to deal with the things you had to deal with, did this give rise to any concerns about, you know, the ability to do your job properly?
Yes, I think it was difficult because there was a reduction in the clinical scientists and the role that we have in microbiology. So I found it difficult eventually when my colleague retired in 2016 that I was really the only person of my grade working in the laboratory. And we had a consultant microbiologist who was on the rota that week for the paediatric patients in the Children's Hospital, whereas before we had a much larger clinical team looking after the hospital at York Hill.
But did this have any practical impact? Did this mean you had to work longer hours, or did it cause delays, or were there any issues?
I had to work longer hours, actually. Yes, I did. And there was more pressure on me because I wasn't sharing the workload that I would have done before.
You were asked in your witness statement about any involvement you'd had at the time when the new hospital was being designed. And you explain in paragraph 63 and onwards that you had no general involvement in the new hospital, although you were involved in discussions about the design of the laboratory within
Yes.
the new hospital. And you explain a number of the steps that were taken to deal with that. Can I just, so we can get another acronym out the way, you mentioned MMT meetings. What's an MMT meeting?
That's the management, so that's the microbiology management team.
And who's the microbiology management team?
That is the microbiology labs throughout the city. So before the move, there was laboratories in each hospital within Glasgow. Now there's only 2, Glasgow Royal and the QH labs, but they were sort of the management team running the laboratories throughout the city, so they would come together and have regular meetings, so that it would be the senior consultants, it would be the lab managers, it would be laboratory managers and clinical directors, there would be some of the biomedical scientists, the clinical scientists. We had an IT system, talking about our telepath systems. We had a person who was involved in IT within the laboratories. Then there would be virology as well, because that was all part of microbiology management team. So it was a big sort of group of people, and it was to run the laboratories within Glasgow, to standardise what we were doing, to make sure that the work was being done across the city was being done appropriately and fairly. Any new advancements in the technology, any changes to our procedures or SOPs, any changes to documentation that we would need to know about, changes in staff, appointing staff, changes in advancement of our technology, introducing new assays, new machinery. So that was generally at that sort of management team approach.
You explain at paragraph 70 of your witness statement, which is on electronic 92, that the way the new building is structured means that the States Department were on the ground floor and you were on another floor of the same building. Is that right?
Yes, that's right.
So if there was any need for communication between estates and microbiology, it'd be pretty easy to do, presumably.
Yes, you would have thought so because we were in the same building, but there was a method of reporting problems to estates So I actually never really went down to speak to someone face to face from estates. They had their electronically FM first. You would log a problem with the estates through their electronic system. So, and then they would deal with whatever issue was. But from a kind of day-to-day working, we really actually, well, I really spoke to estates directly within the building.
Another point you mentioned just shortly thereafter is that there used to be, and we had some evidence from this yesterday, a virology part and a mycology part of the laboratory system, but these were both moved elsewhere when the move happened to the new hospital. Is that correct?
That's correct.
And did this cause any impact on doing the kind of job you were doing?
Yes, I would say so, because it was paediatric virology. So specialist tests we were doing for the Children's Hospital before the move, and quite a lot of the assays were for screening for haematology oncology patients. And it was on site. The turnaround time was good 24, 40 hours. We had good liaison with the clinicians, and we would take the results to the ward every day. The mycology lab was also useful for investigating fungal infections, and we had a consultant clinical scientist who was well experienced in mycology. So it was good to have these on site, but they decided to move them to Glasgow Royal. So it meant that samples had to be transferred to the Glasgow Royal. So they came to the lab here at QH, and then they were transferred by van to Glasgow Royal. Also, the expertise and clinical advice was then given by Glasgow Royal staff as opposed to the staff at QH. So we lost a bit of that clinical liaison with these assays.
Thank you. You also mentioned in your statement, we've heard a little bit about that elsewhere, this thing called the pneumatic tube system that was introduced when the new hospital was built, and you make some comments on it, which you clearly weren't a great fan of it, at least for a while.
No, I wasn't, no.
Did the problems get fixed eventually? Because we heard there were some problems at the start, but you mentioned it generally.
It was improved, and they had to purchase more of the, as I call them, the container pods to go in the system. And they were, for microbiology, they were more expensive and different because they were leak proof. So they had to use a different pod for microbiology samples. So there was no leakage. And we seemed to run out of them. Brenda Gibson was always looking for pods, and at one point she ordered them herself. The samples would end up going to the long laboratory. They would end up in the wrong part of the system, and sometimes the samples never arrived. So there was a delay, and it would break down. But it seemed to be intermittent. It would work for a while, and then it would break down. It generally did get better, but when I left work, there still was some problems with it. And the estates department were having to work with the contractors who installed the pneumatic tube system, because they were responsible for the maintenance of it and doing any repairs to it.
And presumably, and I think you do set this out in your statement, the issue is that you're trying to get a sample from the clinician to the lab, and as quickly as possible. And therefore, if there's some problem and that doesn't happen, that simply causes a delay in them getting a result.
That's correct, yes.
Now, if we can move now forward towards the opening of the new hospital, and we can understand that there would be a period during which construction was going on, and that caused various practical issues, and you've talked about the integration of pediatrics and general microbiology. Then if we go to 96 of your witness statement, I see at the very foot of that page in paragraph 83, you're talking about starting to notice infections not long after patients were into the new hospital. So this was July 25, a small outbreak of something called Serratia. I'm probably not saying this correctly, marquescens?
Serratia marcescens.
Serratia marquescens, thank you. And I see, and on the next paragraph, you explain what that is. Is that one of the first things that cropped up once patients were in?
Yes, that was the first sort of gram-negative environmental organism that we saw in the new hospital. The neonatal unit is separate building from the children's hospital. It's a neonatal, a maternity unit at the Queen Elizabeth University Hospital, and it was refurbished and renovated to allow the neonatal unit from the Children's Hospital at York Hill to be transferred, and that moved over before the Children's Hospital in 2015. And the antenatal service at the Queen, it used to be called the Queen Elizabeth Maternity Hospital, moved earlier to join the maternity patients at the Southern General, and then the neonatal unit moved later.
You then go on from paragraph 85 on to explain how things happen, and one can understand that samples are taken and sent to microbiology for testing, and you explain in paragraph 85 that also in some cases testing is done on admission in some instances to check to see whether there are any infections or the like when people arrive in the hospital. And then you talk in paragraph 86 about calling something called daily macros. What are you doing there?
These are gathering results of the day's reports that have been authorised and also the samples that have been received. So it's an Excel spreadsheet which gives you the type of sample, the date of sample, and the patient's CHI and name, and then the result for that sample. It also gathers samples we've just received, and there's a blanket on the column for the results, so we know that the sample has been received. So on the spreadsheet, it gives you the date and time of the sample.
And you say in your statement, this therefore gives you rather than looking at an individual sample result, it gives you a wider picture of what's happening.
Yes, indeed it does. And
you say that you use them to discuss results with ward clinicians. Did you tend to go to the ward, or did you tend to stay in your building?
We did both. We would have a look at the macros. We would phone out results, and some wards we had a daily visit. Sometimes I would go myself, or sometimes I would go with a consultant microbiologist who was on for paediatrics that day. Before the move, there was my colleague clinical scientist, and we would have different areas of responsibility and different wards that we would visit. And again, the consultant would sometimes accompany us if there was important issues to be discussed.
Now, moving on to paragraph 89, which is on the next electronic page, 98, you're then explaining more information gathering that you do beyond the daily macros and the spreadsheet you just mentioned. You did something monthly as well.
Yes, this was for the wards, acute wards, to have a look at the blood culture results, to look for trends of infections, and the data for the number of patients that in their ward had a blood culture result.
That's something you started at York Hill and you carried on doing in the new hospital?
That's correct. It was started at York Hill, and my colleagues would gather results for their ward that they were responsible for on a daily basis. So the work was split amongst at least three of us at that point.
I you just note at the foot of that page in paragraph 90 that one of the points of all this is if you keep all this material, you don't miss anything.
That's correct, yes.
Can we just move on to paragraph 93 on page electronic page 99. You set out there a number of guidelines that exist for reporting an infection prevention control guidelines manual, an NSS guideline, and an HPS guideline. And are these things that you followed in your work?
Yes.
Can we move on now to paragraph 95, because we start to come to parts of your statement where you're dealing with actual patient events, I can call them that. You say they had 2 patients. Now, who were they?
Sorry,
pediatric
it was when I gave the, sorry, it's badly worded, it's when I gave the statement. It was like a verbal statement on Teams, but they meant the Ward 2A. I should have said Ward 2A. Clarify that.
You expressed a view there that there were 2 patients with the same infection. September 2016, December 2016, and you thought they should have been looked at earlier.
It does indicate that if you have 2 infections of the same organism in the guidelines, that it should be looked at further. However, the infection controlling team would have looked at it and thought the separation in time and space, they maybe didn't see a link because they were 3 months apart. So they look at the patient placement and where the patient wasn't. Was there any connection between the patients at that time? Because it was the same infection in 2 patients.
But as I understand it, the particular infection, Elizabeth Kingia miracola, you describe as very unusual.
Yes.
Now that's based on your experience of what you've seen over your career. In fact, you say it was originally identified in the International Space Station.
Yes, that's correct. It's an environmental gram-negative found in condensation in water, yes. That's where it, so bacterial organisms, they give them nomenclature and they give them names, and then they discovered different bacteria and they give them different names. So over time, with modern technology and DNA typing, they can identify organisms that maybe years ago we wouldn't be able to put a name to. So that's been research from the space station. They've identified different organisms.
But you describe this at the foot of that page as unusual, rarely encountered environmental organism associated with moisture and water and moist environments. You say, going on to page 101, this could have been an early warning sign because there were so few cases. Yes,
that's because it was so unusual. It does suggest that there was something, you know, in the environment, or these patients who are immunocompromised are more susceptible to line infections, have acquired this infection.
I think you've obviously been asked in paragraph 97 if you've ever come across this before, and you said, well, there were 2 patients in York Hill where you saw this particular infection, and then 1 further patient, but this wasn't new because it was one of the same people as had earlier been identified. So why is it significant to spot this organism? Why does it kind of ring a little warning bell to you?
I just think it's, I do remember it being York Hill, and we did look at that more carefully. That's why I remembered the name. It's such an unusual name, and it's named after the person that discovered it. Her name was Elizabeth Kingia. So in microbiology, you learn about different organisms and where they come from, and where they what they mean in terms of infection processes. So this was an organism, just from my experience, that I knew was very unusual and would not be expected to be found in a patient.
I wonder if we could tease this out a little bit. Just for my understanding, am I right in thinking that Elizabeth Kingia as a genus
That's correct,
has
yes.
been known before anything that was discovered in the space station, is that right? But it's the Miracola,
Yes.
which is am I right in thinking that that's the species?
Yes, that's correct.
Right. So, so it's not something, well, the species was first identified in the space station. Is that right?
Yes.
Yes. Now, moving from that, we just tease out what you mean by the finding as being a warning sign. I mean, what do you infer from that finding?
I just felt, from my own experience, and it's a personal view that I put in my statement, that it was, I keep saying the word unusual, but it was different, do you know? And we did see very occasionally organisms at York Hill, but it's like a wee alarm bell. So I thought, that doesn't fit right, that shouldn't be there. It's just with experience, you just feel that unusual organisms are a sign, or, you know, that something maybe isn't quite right. It's just like a hunch you get when you've done microbiology for all these years, that you get a feeling when there's a trend or there's an organism that is not part of the normal microbiology flora or reporting results. You know, it's not in the guidelines. It's not something that you would expect to find.
It's just difficult for a layman.
Maybe it was a bit of
I think
a
really
statement for me to
grasp
make.
this notion, because unusual events may occur unusually, but at least to the layman, they do occur. You had experience of finding Elizabeth Kingia Miracola in York Hill, so it wasn't as if you'd never come across it before. It's my fault for not being able to answer focus the question, but you come across it in the new hospital, and as I say, what do you infer from that?
I think I was inferring, because I'm making this statement retrospectively, looking back at what happened, you know, prior to making the statements. I'm looking back historically at what happened. And when I was asked about this particular organism in the questions that they presented to me, and then I thought about it, and I thought, yes, that, when I look back, that was sort of like the beginning of seeing what I know happened through the years. But that was really the first thing that was like a trigger to me that something maybe wasn't quite right. It could have been there was just a couple of cases of Elizabeth Miracola, and then that was fine, because that's what happened at York Hill. But then we began to see other unusual gram negatives going forward. And that made me think back to, when did we first start seeing this happening? When did we first have an indication that maybe there was environmental problems?
Right. So you're interpreting it with knowledge that you've acquired, your experience
Yes.
of coming across other organisms. Right, I think I have a better understanding now.
Yes, I'm writing this in respect of knowing where we were in 2022 when I gave my statement.
Right,
And they asked me to look back
right,
in time when the hospital opened and when we started to see the infections.
right.
And that was one of the organisms that was actually given to me to discuss by the public inquiry. So that was one of the questions I was asked. And that's why I use the word, Elizabeth, when I encountered it. They asked me, what did I think about the infections? Do I remember the infections with Elizabeth Kingia? And because it's such an unusual name, it's not something that you would forget. So that's where that part of my statement was relevant to now, because it's what happened then, if you know what I mean.
Thank you.
So-
Sorry, Mr.
So
Cobb.
what you had was this very unusual organism cropping up, you say in September 2016, and then again in December 2016, and then again in February 2017.
Mm-hmm.
So you had 3 Elizabeth Kingia
That's right.
miracola
Yes.
incidents that you were looking back at.
Yes, I think it's 3. Yes, 3. Yeah. So 2016 to 17, there was 3 cases.
Just on a point of detail, if we go to 103, please, in paragraph 106, we're back to Serratia marquescens in July 2015, and you were covering somebody else's work, and you became aware of these results, and there were some meetings which you were not involved in. This is paragraph 106. Now, you say in your statement that HPS were aware of that. I've been asked to suggest to you that HPS wasn't aware of the Serratia marquescens until later in 2015, probably December. Can you help us at all on that?
Right. So I was covering for a colleague who was on annual leave, and the 3 babies were found to have Serratia marquescens in their samples. And then there was a positive blood culture. So I informed infection control team, and they had some meetings, and I wasn't attending any of these meetings. When my colleague returned, then she took over and continued with the investigation, because her remit was the neonatal unit. So I didn't contact Health Protection Scotland, but I was aware. I've used the word aware because I was aware they were contacted at some point, but I wasn't sure when. I didn't contact them. I contacted infection control, and they were aware of the cases. And I think we may have been further cases that were dealt with by my colleague and Professor Williams.
Thank you. So you can't be sure when they were contacted because it wasn't something you did?
No, but I wanted to document that they were informed.
They were informed?
Yes.
And I think you go on in paragraph 107 to explain to us lay people what colonization means, which is that essentially you found a particular organism, but it's not invaded the bloodstream or tissue of the person. Is that correct?
That's correct.
And I think what you're explaining there is that you find it, you don't always do anything about it, but you tell the relevant doctors about it because it's quite possible that the organism that's colonized will later get into the bloodstream, and then they know what it might well be.
That's correct.
That's the essence of it.
Yes.
Now, on page 104, the heading in your statement is Infection Concerns 2015 onwards. and you start then to tell us about things that you found. Now, I know some of this is contained in a PowerPoint, which we'll look at later on, but if we can just go through this. In paragraph 110, you say in 2016 there was an increase in the number of positive blood cultures. Was this something that was of interest, of concern? What was your thought process?
I would say both. It was of interest and of concern that when the hospital first opened, the hospital, was always should be a clean environment, and you find that it's in the literature, when a ward is opened in a new hospital or a new hospital is opened, there is a much lower level of infection because of colonization and bacteria in the environment. It's clean, it's new, all the equipment's new, and then you start to see infections perhaps post opening of a new hospital. So we did have a year where there was fewer infections, but then in 2016, and that takes me back to the Elizabeth Mericola story, it was 2016 we started to see an increase, like a trend, in the number of blood cultures that were becoming positive in the hematology oncology patients.
And what you've done, I think, is tried to put together some analysis of what you had found to try and understand what was going on, essentially. Is that right?
Yes.
Because we find in paragraph 111 on electronic 105, you talk about 2014-15. Now that was before you moved, and then 2015-16, 9% percentage of positive blood cultures, which was the same as you'd had at York Hill. That's which correct. You thought was still higher than it should be.
Yes.
And then 2016 jumped to 15.5%. Is that, for a layperson, difficult to know whether 9% to 15.5% is significant or insignificant?
I would say yes. It's an increase. It's a jump. I use the word jump because that actually describes you've got a jump from 9% over like 2 years to stay about 9, and it's up to 15. So that is quite an increase. But moving forward, it was the next year. It was like a trend. So you sometimes get an increase in your blood culture for whatever reason, and then it might fall down again if there's better practice or intervention. But what we were seeing was an increase year on year. And that's when I first saw the jump from the 9% to the 15.5%.
When you talk about positive blood cultures in this context, that means the presence of any microorganism in the blood?
Yes.
Right. Thank you.
So it's a percentage, it's a number of blood cultures taken from that patient group, and then the number that were positive and grew an organism. So it's a percentage of these two figures.
Because one does not expect to find microorganisms in the bloodstream.
That's right. Your blood culture sample, which is put into special bottles to grow bacteria if they're there, your blood should be negative. You shouldn't have bacteria in your blood.
Thank you.
If you have bacteria in your bloodstream, that's considered a bacteremia or a sepsis. So it's an infection within the blood. So it's systemic throughout the patient's bloodstream.
What you deal with in paragraph 112 is not just numbers, because you talk about peaking in 2000, starting to peak in 2017. You say the other interesting thing from my perspective was the mixed blood cultures. Now, just so His Lordship understands the point you want to make about mixed cultures, can you just take us through this quite carefully, please?
Yes, so I think someone may have referred to the past, but when you have a blood culture and it's positive with a bacteria, it's usually one organism, like from a urinary tract infection, like an E. coli, or from a wound, a Staph aureus. One specific organism related to the patient's clinical history and what the patient has been admitted to hospital for and what reasons they may have a sepsis. Other things like meningitis can meningococcal infection, group A strep, we'll see a lot about that. They'll cause known clinical infections when the patient's blood has got an organism in it. What was happening here was it wasn't just one organism. So we were growing from our blood culture bottle 2 or 3, sometimes 4 different organisms, which we had to culture and identify. And the report would be sent out to the clinician listing the organisms that we had isolated from this blood culture. Now that in itself is unusual, but can happen with a line. When you have a line, when the bacteria can be introduced from the line, the patient's line, whereas other bacteria that cause bloodstream infections are from the patient's infection, like I said, from a urinary tract infection or from a wound. So you don't expect to have what we call a mixed infection.
I think there was just a little bit of that I didn't pick up. Multiple organisms in the blood are unusual.
Yes.
One explanation of that is that the source has been the line. In other words, I take it an intravenous line connected with the bloodstream in order to provide chemotherapy or antibiotics. Now, you said something else that I missed. You identified that a line was a possible source. Now, you said something else which I just didn't hear after that.
I'm not sure.
Or maybe you didn't.
I just compared the mixed infection with a single organism infection, which is what you're asking me. So
right, okay.
The difference between having one organism in your blood culture result from your blood compared to having more than one organism.
Okay.
Yes.
Thank you.
And is this something that bothered you, seeing
Yes.
these mixed things?
Yes.
And you set out in your statement some of the statistics, as it were, that you were able to find that in the year after the move, you had 11 samples with mixed organisms. Then June 16 to June 17, 36. And I think, in fact, you go on in paragraph 113 to say in June 17 to 18, 40. That was something that was bothering you.
Yes, again, it was something that, again, using all my experience in microbiology, you do get the occasional, as I say, mixed culture where there's been a contamination or there's been line use where you would see an occasional blood culture with maybe skin organisms, but this was a larger number, 40 blood cultures from that patient group with more than one organism, and not only just the organisms themselves, but the type of organisms that we were seeing.
And why is that significant?
Because we were seeing a mixture of different gram-negative organisms in the blood culture.
Sorry, did you say of different gram-negatives?
Yes, different gram-negatives.
Thank you.
You describe gram-negatives in your statement as environmental organisms. Just explain to us why you label them that way.
Right, well, there's gram-negatives that are what we call not environmental. So they are from the patient's, they can be from the patient's own flora, like from the gastrointestinal tract, from a urine. So they are from different organs of the body, or like a renal problem, from the patient that have become like a sort of a colonization, for example, as well, we're talking earlier, that can then become an infection. But the organisms we were seeing in these mixed infections were not what you would expect. So they weren't like an E. coli or a Klebsiella or an Enterobacter. In some of them, there were 3 or 4 different organisms that we would describe as environmental.
So that means they come not from within the patient, but from somewhere external.
Yes, it does suggest that, yes.
Is it the case that bacteria necessarily fall into a classification of environmental or non-environmental in their source?
Yes.
And would you expect those with the appropriate expertise to be agreed as to whether you can classify a bacteria as environmental or non-environmental
Yes.
in its source? Thank you.
And what you go on to say in your statement at page 106 onwards is that you pulled a lot of this together and you did a presentation at the request of the clinicians in the Schiehallion unit on what you were finding. And you also explain the existence of something called the CLABSI, Central Line Associated Bloodstream Infections Group, which was looking specifically at improving the precautions around lines. Is that correct?
Yes.
And you're very positive about the efforts that they made. So can we go on to page 107, paragraph 118? We've talked about numbers, we've talked about environmental organizations. In paragraph 118, you then say another point was diversity of organization. Paragraph 118 of your statement. You have that?
Yes.
So you're saying that diversity was also an issue?
Yes, so the type of species that we were seeing was wide-ranging, so it's not like you have a single point infection where you have one organism infecting people, so it's a common source, and it's the one organism that's been found in various patients within a ward. So it's a concern that there's an organism in the unit or in the ward that's been infecting the patients, for example, like a Staph aureus infection within a ward. But this was very different organisms, and the diversity means that they were very different, and the names are names that our staff hadn't heard before. And as I said in my statement, they were looking them up because they would see them in the results. They were working on the benches and they'd say, oh, it's come back as this organism. And they were looking them up and finding out. So they were interested in this type of organisms that we were seeing. So the diversity means that the wide range of, it wasn't just like 1 gram-negative environmental organism we were seeing a wide range of them.
And did I understand you to say that these were so unusual, people were having to look up to see what on earth they were?
Yes.
So presumably very unusual.
Yes, some of them I hadn't heard of before. In all my experience in microbiology, it was the first time I'd come across these gram-negatives. So there's a few of them that even I had to look in the literature and do some research on.
And just to continue the story, because you've explained how some of the technology works, but can we go on to paragraph 121, which is electronic page 108. And you say there we identified a couple of unusual organisms first, and then a diversity. Then we saw the same organisms reappearing, then disappearing, then coming back again, then mixed infections. So seem to be coming and going, is that right?
That's correct.
And you use one organism I think, to try to explain your point, Stenotrophomonas multophilia. You see in the middle of paragraph 121, you said it was a new find, first isolate April 27, and then you explain that It was one in April, May and June, then 2 patients in July, 1 patient in September, so it seemed to come and go, is that right?
Yes, it did. And I did plot a graph of the central pulmonis infections over a number of years, and it was like a space of 2 or 3 or 4 months when there wasn't any infections. Then it would come back. And as I described, it was small clusters. You wouldn't just see one on its own, you would see 2 or 3 patients with it. And then it would go away, is the best word probably to use. And then you would see it again. I don't know whether there were interventions or something happened why we didn't see it for a few months and then it came back again. So I couldn't have used it like an indicator organism. That's, I think I've described it as that, because it just gave me the feeling that things weren't quite right, because when the Stenotrophomonas monas appeared, they also appeared at the same time that we saw an increase in the total number of blood cultures that were positive. So at the time when we saw an increase, like a couple of months, you would see a trend increase in your number of blood cultures that were positive in these patients. You would also see some of them with Stenotrophomonas. And also some of the patients with Stenotrophomonas multifilia weren't single organism blood cultures. They were mixed with other environmental gram negatives as well. So they had more than one organism.
I think I'm just saying back to you what you've just said to me. This was something you were noticing at the time.
Yes.
And I apologise, Mr. Connell, and we'll sort of shut down the question if this is something you're coming to, but were you talking to colleagues about what you were seeing in the lab results? I mean,
Yes.
were you discussing this with clinicians?
Absolutely, both speaking to the clinicians, if you spoke to them, they would confirm that I would speak to them. They saw the trends. A couple of them particularly were interested and asked me to send them some results. So there were definitely consultant hematologists and oncologists who were interested in these organisms, and the mixed blood cultures in particular. One of the consultants was very interested in that. I also was informing infection control and my line manager, whoever was working with pediatrics that time with me, because at that time I was working as a clinical scientist on my own because my colleague had retired. So 2017, it was just me pulling these results out. So I would every time, and they would go to the authorization queue, so we would see that one. But no, I was communicating the results of the Stenotrophomonas, yes.
And these clinicians would include Professor Gibson?
Yes. I mean, and for example, Dermot Murphy was very interested in it as well.
Thank you.
The point that you make, I think, in paragraph 123, which I wanted to just ask you about, is that you find them, you discuss them with clinicians, you discuss them with your line manager, and you report them to infection control. But unless you're actually at an IMT or something, you don't actually know what action is then taken to deal with whatever the infection is you've identified. Is that right?
That's correct.
You say you don't have feedback on what corrective actions were put in place. Just thinking back, would it have been helpful for someone to have come back to you and said, "Oh, you've reported on this mixed infection. We've done X or we've done Y."
Yes. It was maybe a bit out of context, but I did know that in June 2018, they used HPV in the ward to help reduce the level of infection. So I did know about that. And that was in June 2018. And then the blood culture rate positivity in July literally went down to below 5%. So I did know sometimes that there was an intervention, and I could see that the corrective action or whatever was having, a positive effect. but I didn't always know. If you see my graphs later, they go up and down, but there's a moving average changes, you know, month to month, but the trend was upward.
So whatever was being done wasn't stopping this trend. It might have made the graph go down for a bit, but it was going back up again.
That's correct, yes.
If I can oversimplify.
Yes, that's correct.
I wonder if we could look at bundle 27, volume 6, 107, please. Now, this is a 2018 production by Dr. Peters and Kathleen Harvey-Wood. Is this something you put together, is that right?
Yes.
Is this in the form of a presentation that you made that you've told us about to the clinicians?
Yeah, it was a PowerPoint presentation, and we gave it to the hematology oncology clinicians they have a lot of wards have like educational lunchtime meetings for training, and quite often microbiology was invited to go to the ward to discuss a particular case or an unusual infection or a change in our technology. We would be invited to the ward to their academic sessions, which are usually held weekly, to do presentations, and I did quite a lot of presentations during my career. So this was one that was prompted really by the hematology oncology consultants, because by 2018 they were aware of this trend and increase of blood cultures being positive. So Christy and I put together this PowerPoint presentation and gave it to the clinicians and the staff. And I think some of the CLAPSI group were present as well at the meeting.
That's the group that were working on improving the rate of line infection.
Yes.
Perhaps we could just look briefly at this presentation. Could we just scroll on to the next page, please? Now that's simply numbers.
Yes.
Numbers of cultures taken.
Yes.
So does that graph tell us anything particularly significant?
Yes, actually it does, because what they were trying to say that the blood culture percentage positivity rate had increased because they were taking more blood cultures, because if the children were unwell, one of the things you do when a child becomes unwell or has a fever is you take a blood culture. So the question was asked that maybe they're taking more blood cultures and that's why more are positive. So I looked at the number taken each year and compared it with 2014 and 15, which is the year before the move. And as you can see, there actually is not an increase in the number of blood cultures that were taken for these patients.
The 2014-15 would be in York Hill.
That's correct, yes.
So,
sorry, again, it's just maybe I didn't pick up what you said. Did you say that somebody suggested that, well, the reason that there's more positives is you're taking more samples?
Yes.
I mean, was it somebody who suggested that?
Yes.
Who suggested that?
I honestly can't remember.
Right, okay.
can we just move on to the next page, please? 109. What are we seeing here? So we've got numbers taken, which is taken from the previous graph.
That's correct, yes.
And then number of patients positive is in the reddy brown colour, and then a percentage. So what are you explaining with this graph?
So I've superimposed the number of blood cultures taken as a reference point to show that the number of blood cultures taken in total hadn't changed. What this blood culture shows, if you compare with the results 2014 to 15 prior to the move, you can see the first year we were in the new hospital site that the number of patients with a positive blood culture and the percentage had fallen even compared with our previous results at York Hill.
So that's June 15 to 16.
16, correct. And then if we move forward to June 16 to 17 and 17 to 18, you can start to see the increase in the number of patients that had a positive blood culture, and the percentage positivity rate was starting to increase. So that goes back again to we seeing this change in 2016 to 17.
And although you described it as percentage of patients with positive blood cultures. That means percentage of samples which produce a positive result. Right.
We go on to page 110. Now, I'm assuming that the red line is intended to indicate a general upwards trend. Am I right?
Yes, that's a trend line. So that's what we call a trend line. So that shows the trend in the positive blood culture. So you can see in June 2014, it was below 10%. It was about 8%. And that's what I spoke about earlier, that the rate at York Hill was about 9%. So if you're wanting to use it as a comparator, that's where it was prior to the move. When we moved to the new site, it was 10%. So it was sitting, like I said, that's the figure that was 9.9%. So that's the same as it was prior to the move. In moving forward in time, you can see that the trend is an upward trend in the number of positive blood cultures, the percentage of positive blood cultures. And you can see the two peaks, which is April 17 and March 18.
Yep.
When it was about 27% of the blood cultures were positive. So that's over a quarter.
That's quite a striking difference to
It
what you
is.
had in York Hill.
Yes. So the red line, as I said, is a trend line. The black line, which goes back and up and down, it's what we call a moving average. So that's what I was referring to, in that some months the blood culture rate would be higher than others. For example, February 16 is well below 5%. So there was this variation in month to month, but overall the trend is an upward trend, going from less than 10%, about 8-9% in 2014, to about 16-17% in June, July of 2018. The reason I put the HPV, which is hydrogen peroxide vapor, in was because that was quite a remarkable change in the number of positive blood cultures. It was done twice in the ward, and the next month the blood culture rate went down to 3%. So I annotated that on the graph because was that the reason? I don't have enough information to back that comment up, but it looked for me, just from a graphical point of view, just looking at the graph, and that's why I put it in a different colour, it does stand out as what happened then to improve the number of positive blood cultures.
Thank you. Can we go to the next page, please? I don't want to go into each and every item you have in the presentation, but I'm right in thinking this is another representation which you say shows something similar.
Yes, so this is one of Christine Peters' graphs, but just to kind of briefly go over it, because it's quite complicated. The red arrow shows the move to the new hospital at the QH site. The different colours are the different types of organisms that were isolated from the blood cultures. So if you look at the peak, which was April 17 to June 17, which I've already mentioned in the previous graph, you can see by the colour charts the different type of organisms that we were seeing. I think what Christine's trying to show here is, if you look at the dark blue colour and the purple band, you can see, comparing that, now the dark blue and the purple are environmental organisms, it's ENV, and the purple's ENT and ENV. These are enteric bacteria and environmental bacteria. These are bacteria that can be both. They can come from the environment, they also come from the patient. Whereas the green line, the green square, is enteric. These are bacteria that you would find in blood cultures from the patient's GI system, for example. But what this graph shows is that if you look at the purple and the blue, you can see that at the beginning of the hospital move in June 15 to, for example, March 16, that's that first year I've already discussed, there was very little, in fact, there wasn't any. If you look at the graph, there was no enteric environmental organisms. And if you look towards April 17, you can see that band of blue and purple. Thank you, it's much bigger, it's increasing in size. If you go on to April 18, which again I referred to earlier, was the other peak in the earlier graph, you can see again that the band of purple and dark blue is larger in size.
So you're essentially seeing more environmental or possibly environmental organisms
Yes.
appearing. Yeah. Okay. Let's just see what else is on this presentation briefly. 112. I take it that's just another way of presenting the same material.
Leave the previous
We'll go back to 111.
Yeah. I mean, one thing that's striking about this is the contribution of what you've identified as enteric. In other words, infections which derive from the patient himself. Is that right?
The enteric's green. Yes.
I'm looking at the green.
I can see that. Yes, green. Yes, the green is increased as well. Yes. So generally, in general, all the blood cultures had increased. There was an increase in blood cultures. But along with that, there was an increase in the environmentals. Because if you look then at April to June 2018, the very last column,
yes,
you can see that the green has become much less.
Mm-hmm.
And the environmental has become larger. So what happened was we saw a change or a displacement from the enteric organisms to the environmental organisms.
And the y-axis is numbers of samples.
Yes. Yes.
It has been suggested that take a step back. What you're presenting are the blood samples taken from patients in the Schehallien unit. Either, I mean, it's the same description of patients, either before 2015 when the Schehallien unit was located in York Hill, or after 2015 when the Schehallien unit was located in the new Royal Hospital for Children. Now, I think it has been suggested that the experience in York Hill, or the experience after the move in 2015 and therefore in the Royal Hospital for Children, was not different from the experience in York Hill. I think it's fairly obvious from the presentation that that is not what is apparent from the PowerPoint presentation.
I would agree. This PowerPoint presentation suggests that there definitely was an increase. And I know I've not been asked, but if I could just include Sid Mockery's independent expert report, which I've had a look at. His results...
Well, I think we're talking about a report which was tendered by GGC. I think we'll leave that.
No, that's fine. I am aware of it.
I think we'll leave that for the moment, at least for the moment.
Thank you.
Right. Okay. Mr. Connell.
Yeah, I think we're getting the message fairly clearly that you were trying to portray with this, which is increase in comparison to York Hill. So I think we can probably just glance at the other slides while we have it up. 112, please. Are we seeing this just a different way of representing something similar?
Yes, it's just showing the blood cultures with the different organisms. So it's separated them into gram-negative, that's GN,
Yep.
gram-positive, GP, and other organisms. And that might include the yeast and the fungi and other types of bacteria. So what really, again, I think is to look at the part of the graph once the hospital had moved in July 15 to September 15, and you can see the drop in all three of these different graphs.
So that's your experience that you, in fact, I think you mentioned it was covered in the literature that usually when you open a new hospital, you see an immediate,
Yes.
an instant drop.
Yes, that's recognised in the literature. So that's what you would expect in a new clean hospital. But I think this again is one of Christine's graphs, but I think if you look again to the end of the graph, the last column, this is where we're trying to show a change and a switch in the type of organisms that we were seeing. So you can see that the gram-positive organisms has fallen, but the gram-negative organisms is increasing. Thank you.
Thank you. We look at 113. This is again a similar colour-banded chart.
Mm-hmm.
Just tell us in a couple of sentences what this is telling us.
So this is showing the gram-positive organisms, sort of to compare it with the gram-negatives. The most common gram-positive organism that you see in a blood culture is a coagulase negative staph. It's in as CNS, which is the sort of dark red.
So this plots the gram-positive.
Yes, so that's a skin organism, and that is found in blood cultures.
Yeah.
When a child is septic, it can be a contaminant from the skin. It doesn't always cause a serious deep-seated sepsis. However, if the child is immunocompromised and has a line, then coagulase negative staph can be an infection that would need to be treated, and the line is colonized. The other organisms, just to give a comparison, for example, MRSA and MSSA is Staph aureus. So these are organisms that you would find in a blood culture, and vector control keep a close eye on Staph aureus and MRSA. But the striking thing for me is that there wasn't a lot of these common, if you call the word common, but infections that are part of our HIAT and infection control would want to monitor is what we call SABs, Staph aureus blood cultures. The SAB.
Could I just have that again? What was striking to you was there was not a high number of
SAB, so that's SAB, it's Staph aureus bacteremias. And that is shown in the blue square and the purple square. So the blue square is MSSA, that's methicillin sensitive Staph aureus, and the purple square is MRSA. These two organisms are used in hospitals to monitor bacteremias. And you can see with this pediatric population that it would be very different from the adult population. And coagulase negative staph, which are a skin organism, there's a predominance of them. So it was just really to give an oversight of the gram-positive organisms because we've already shown the gram-negatives. So it's to show, in context of that graph that we just looked at with the gram-positives and the gram-negatives, that's put into a different presentation there, a different format.
Thank you. 114. And you've done the same for gram-negatives.
Yes, so this is teasing out from that really big graph with lots of bands in it. So this is actually, in more detail, shows you the organism we're talking about. So they've got the environmental and the environmental enteric. and the same colour scheme is being used throughout the whole presentation. So you can see that the dark blue and the purple in the columns from April 17, which was a kind of peak month, and then again in April 18. These are the two times in the timeline that there was a definite increase. And these columns show the breakdown of the type of organisms that we were seeing. So you can see that amongst the gram-negative organisms, the trend was a definite increase in these environmental organisms in the dark blue part of the column.
Thank you.
And you can look back and compare it with the move. So you can see that there was very few in the first quarter of the first part of 2015 into, you see the column there with the little orange square, that's with contam. There was no environmental at the beginning when we had the move to the new site. And then the next column is enteric organisms, which you would expect, so October to December. And also look at the numbers, not only the different organisms that we're seeing, but look at the trends, look at the numbers, the height of the columns. So if you compare that with pre-move as opposed to post-move, you can see the difference in the numbers as well as the type of organisms.
Now, are there any other graphs on that presentation, or have we been through them all? Can we look at 115? Does that tell us anything new, or is it simply...
It's just teasing out the graph. It's the same as the previous graph, only we've taken out of it.
Environmental gram-positive,
yeah, we'll just put them in. Yes, So you can see, you can see that they've taken the other organisms out and just left the environmental and enteric environmental. So you can see that space in June 15, so January 16, you can see there wasn't any at all. That's quite, the presentation of that graph does give you an indication of what I was talking about earlier. In April 16, I began to see things in the blood cultures. You were talking about earlier, Lord Brodie, about a trigger or a sign or a signal. So you can see from this graph that going back and taking a look back to when I saw this happening, the graph shows that there was a trend, and looking back at that time, there was a change, if you can see what I mean, between having no environmental organisms to starting to see them.
Thank you. Don't know whether there are any more. 116? And that's just, we start to get into listing of organisms rather than graph representations. Yes. Is that correct?
Yes, so just to kind of summarise what's here, this is a list of the organisms. And that actually refers to what I was talking about, the diversity of the organisms. I mean, they're scientific names, and some of them are difficult to pronounce. But these are the type of organisms that are not what you would usually find in a blood culture.
Thank you.
And obviously, as we already discussed, the Serratia marcescens and the Stenotrophomonas multifilia are in this table here.
I think we can leave that PowerPoint now, if we could. And I think just at the moment, I just want to ask you a couple of questions just to finish a section of your statement. You've explained to the inquiry earlier how it came to be that you were sometimes at IMT meetings. And you were asked, and we find this at electronic 111 of your statement, paragraph 131, that I think you basically asked, how did you find these meetings when you were there? And you said, well, basically, when it's the clinicians and the infection control people and people from microbiology, it's all fine. Mm-hmm. But then sometimes with the people from outside that group, you get differences of view. Is that right?
Yes.
And then you say in 132, you can't tell us which one it was, but you do have in your head a meeting at which you were told that what you were seeing was normal, that someone was saying that 40 positive blood cultures a month was normal, and you had had a view about that.
Yes, so going forward in my statement, once I was given my witness statement bundle of IMTs and minutes to go through in preparation of later parts of my statement, then at that time when I was writing this part of the statement, I didn't have the memory, but then I was given the minutes in which this this situation occurred. So I do now know who it was, and I think I do refer to that later in my statement at the IMT on the 14th of August 2019.
Is this Dr. Kennedy from the board's public health team?
It's Dr. Kennedy and Christy Hinn, yes.
And you got the impression that they were saying, well, this is just normal, and you didn't agree?
Yes.
So just to clarify that, looking at paragraph 132, you say they were trying to play it on. There was someone in Public Health Scotland. So although in the statement you refer to someone in Public Health Scotland, it was in fact Dr. Kennedy.
Yes.
Right. Okay. Thank you.
Yeah, I think this might be an appropriate time, Lord, to pause.
Ms. Harvey-Wood, we usually, as I said, take a coffee break. I think, could I ask you to be back for 12 o'clock?
Thank you.
Right. You'll be taken to the witness room.
Thank you.
Mr. Conn.
Thank you, Lord. I'm going to divert just in a moment from your statement to ask you about a particular organism. But before I do that, can I ask you this? Did you maintain some kind of data set of the testing and identification of organisms in the paediatric wards at the new hospital?
Yes, I did.
And did that cover all of the wards that fell within that paediatric section?
Not all the wards, just the acute wards.
The acute wards. Thank you. Now, I want to ask you about an organism called Mycobacterium chelonae, or chelonae, whatever the correct pronunciation is. I'm told that on the list that was on the PowerPoint that we've just looked at a short time ago, we don't find Mycobacterium chelonae mentioned anywhere. Do you know why that is?
I think at that time when the PowerPoint presentation was produced, it's a gram-positive organism, so it's not environmental gram-negative. And at that time, it wasn't in our list of alert organisms, so it wasn't included in the presentation.
Had you encountered that organism when you were in York Hill?
Not that I can remember.
And did you encounter it in the new hospital?
Yes.
Can you remember anything about how that occurred?
I think we had two cases. One was from a blood culture, and one was from skin infection.
So you remember discovering this particular organism?
Yes, yes.
Was that an unusual organism?
Yes, it is indeed, yes.
Is it listed on something called the National Infection Prevention and Control Manual? Do you know?
That's a very interesting question, actually, because if I refer to Appendix 13 in 2021, which I have a printed copy of.
That's Appendix 13 of this manual?
Yes, this document has changed in time in respect that the organisms that have been isolated in the QH-RHC hospital, Children's Hospital particularly, have now been included into this appendix, so it's been updated on various occasions. The most recent version in March 2024 includes a lot of organisms which weren't in the appendix in 2021, which I referred to in my statement. And prior to that, in 2017, there was no gram-negative environmental organisms in the appendix of the, it's a national document for Scotland.
And what's the significance of an organism being in the appendix? Why does that matter?
It highlights to the laboratories that these organisms need to be reported to the infection control team and in some instances to Health Protection Scotland. They're called what we call alert organisms.
Thank you.
And laboratory staff should be aware.
I think I got that. Alert organism.
Alert, AL, yes, alert. That's on the, I think it's on the heading of the appendix. I do have a copy here. I think it says alert on it.
So you were explaining to us how this has developed, and a lot of organisms located at the new hospital are now on the alert list.
So, for example, in 2017, they actually added for the first time environmental gram-negative table, and that included 4 gram-negatives, and it's 4 that we saw in the Children's Hospital. Pseudomonas aeruginosa, I think, was added because of the infections in Belfast. Then we had Serratia marcescens, Stenotrophomonas multifilia, and Acinetobacter. These 4 organisms were added to the appendix around 2017, if I remember correctly. In my copy in 2021, they are listed, the gram-negative organisms.
Can I come back to the question of Mycobacterium chelonae? Do you know where, or does it appear? And if so, when did it appear?
That's what I can't look back, because on the website it won't let you look at previous versions.
Right.
But the version on the website now, which was updated in 2024, does include Mycobacterium chelonae, along with other organisms that we have discussed. I mean, I can list them if you want, but you can look at it online. Some of the fungal organisms have been included, including Cryptococcus species. So this is a manual that is updated with regard to infections and organisms that have been seen in Scotland, and in particular from Rosa for Children. So if you go back in time when we're looking at this appendix, these organisms weren't there as alert organisms.
There's quite a lot of detail in that, and I don't think it's dealt with in your written statement. I'm just wondering if I could ask you maybe just to review what, or, well, let's see if I can just take it at dictation speed. And now, you were asked about Mycobacteria chelonae, and you began by saying that in 2018, this gram-positive organism was not in, I think you said, our list of alert organisms.
No, so I should say the Appendix 13.
So is that a reference to...
The reference that I used in my statement, the date of the manual date in my statement that I referenced to.
The paragraph in your statement?
Appendix 13, I do refer to, I'm not sure where it is. I do refer to this Appendix 13.
Okay. Anyway, in relation to 2018, when you're talking about a list of alert organisms, is that a reference to Appendix 13 of the National Infection Prevention and Control Manual?
It's a reference to the appendix, yes, because we use it as a reference point for alert organisms, and it says that on the first line of the document. But this is changed and updated versions as different organisms are found in hospital settings that are found to be infection control and of a public health interest.
Now, and you've explained that we can find the manual online, but we will only find the current version online.
That's what I was able to find myself. I was looking back to find the document that I'd referred to in my statement. I do have a paper copy, but I was only, when you click on Appendix 13, you get the current version.
Right.
And that was updated in March 24.
Right. Now, you took us back to 2017 when there was an update of Appendix 13.
I think there was, I can't be certain, but I have written in my notes that there was an update in 2017, and that was to include the environmental bacteria.
Which had previously not been alert organisms.
That's correct.
And
I'm not sure on the time it was put onto the manual appendix, but I think it was around about 2017. I can't go back to verify that because...
Now, again, if I've noted you correctly, 4 gram-negative organisms were added to the alert list in 2017. Now, you listed them.
Yes.
And too quickly for me.
Yes, I'll give them again, sorry. Pseudomonas aeruginosa.
Pseudomonas.
Do you want me to spell it?
Do
you want me to spell it?
Yes, please.
Okay. Right.
I've got the Pseudomonas bit.
So it's A-E-R
Right.
UGINOSA.
Right. And next one?
Acinetobacter species, and that's again in my statement, it's ACINETOBACTER.
Right.
The next one is Stenotrophomonas multifilium.
Right. I think I've got that one.
And the fourth one is Serratia marcescens. Serratia, yes.
Serratia. Right.
And we've spoken about two of these already. It then says that, so they also put on the manual the setting where these organisms would be in alert. So some on the table will say all hospital care settings, or all clinical settings. For example, the Staph aureus that I spoke about earlier is all clinical settings. In this respect, for the environmental bacteria column, it says high-risk units, PICU, ICU, NICU, oncology, hematology. These were the areas that we were actually seeing these organisms in the children's hospital. The ICU refers to the adult, which I'm able to comment about.
Right. I think I've probably got enough. Sorry, Mr. Collins.
And I think you were asked to refer to your statement. Am I right in thinking that in paragraph 93 of your statement, you refer to the manual as one of the things that you have to follow?
Yes, yes.
And you'll have referred to whatever version of the manual you had available to the time you were preparing the statement.
Yes, indeed. So it has been changed since I made my statement.
Thank you very much. Can I ask you some more questions, I'm afraid, about Mycobacterium chelonae? On the two occasions when you say it was found, was there any particular action you took that you can remember?
Yes, I would have informed the ward and the clinician, and also the consultant who was on for paediatrics at that time, and probably the clinical lead, Christine Peters, would have been informed as a clinical lead at that time.
Did you ever report it to RHI?
I don't know if that would be my responsibility to report it to RHI. I think that would go through the infection control team.
Did you ever report it to the National Reference Laboratory in Edinburgh?
The reference laboratory in Edinburgh, the TB reference laboratory, also can confirm and speciate non-tuberculosis, which are called non-tuberculosis bacteria. So they would have had both of these organisms. They should have been setting them for confirmation and typing, and they would have been informed, and then they would email us back or inform us of confirmation of the result, because our laboratory would need to have that confirmed in a second reference laboratory.
Can you remember, were you involved in the identification of antibiotics to treat any patient with Mycobacterium chelonae?
I didn't give advice on the Mycobacterium chelonae infections. That would be a consultant microbiologist. So at that level of infection, for example, like for tuberculosis as well, that would be something that I would inform the consultant, who would then deal. So with more serious infections, the remit for that advice would come from the consultant microbiologist.
You explained to us about the what you call the telepath system, basically a recording system on which you carefully noted everything. Can you remember ever recording information about Mycobacterium chelonae from the pediatric wards in 2015, 16, 17, 18? Can you remember at all?
No, I can't remember. If I'd reported out a result, I would have had my name on the report, so it would be in clinical portal. Then that person would then authorise the report and then deal with the reference lab results. I'm not sure if I had any dealings, but I would have recorded anything I had done in telepath, so I can't look back and check. But everything I've spoken about today, if I had dealt with anything, I would have recorded it. So,
Yep. So I'm really being asked, or you're really being asked rather, if you can ever recall getting information about this particular organism, not the 2 patient identifications, but from anywhere else in the hospital.
no, can't remember, no.
Do you know anything about when water would be tested for the presence of Mycobacterium chelonae?
No.
Can you tell us whether there's anything in your reporting SOP or quality management SOP about that particular organism?
We do have a reporting SOP and an alert organism SOP. When I say alert, it's similar to the national guideline. We have our own laboratory SOPs for guidance on when to report an organism to infection control, when to report it to Health Protection Scotland. At that time, I can't remember if Mycobacterium chelonae was in it. TB, like tuberculosis, was definitely in it. I didn't really deal with these cases because of them being kind of under the umbrella of tuberculosis, although it was an atypical. So at my level, I didn't always deal with these infections. So I'm not sure if it was in the SOP, but you could access it from the department.
Just a question of detail. I mean, I think you've explained it. I think we maybe noticed this before, that Mycobacterium chelonae is described as an atypical.
That's right, yes.
Could you just maybe tease out, I mean, what is meant by atypical?
Well, the tuberculosis bacterium known as TB causes a lung infection, and it's very infectious, difficult to treat, and even with the WHO, it's recognised as a severe infection, as a communicable disease. They call it communicable disease. It's very easy to transmit. The atypical or the non-tuberculosis bacterium are different in that they are not as infectious and they have different disease processes in that they cause a different type of infection. And the word again, and some use it again, is common. They're not common. And in normal, fully well and fit people, it may not be a problem. The reason they are of interest here is because of the immunocompromised patient. Patients that are immunocompromised have a very weak immune system, and they're more susceptible to these type of infections. So it's in that setting that it would be causing more of a disease than it would in a normal person with a competent immune system.
I think my question was perhaps more focused on why Mycobacterium chelonae comes within what I take to be, and I may be wrong about this, a larger group of pathogens which are described as atypical. Why is it so? I mean, I think I understand it has a different disease process
Yes.
from
Tuberculosis, yes.
But why does it come to be referred to as atypical? There may not be any obvious reason.
I don't know if I can actually answer that question to explain from a scientific point of view what it means.
Maybe it may be enough that
I think it's a different
I know
disease.
that when I see a reference to atypical organisms, it includes Mycobacterium chelonae.
And abscesses. Basically, it's the non-tuberculosis. That's why it was called non-tuberculosis. It's all the different types of Mycobacterium because it's a big genus of organisms with lots of subspecies. Now, the tuberculosis if you want to call it the true TB, is a disease process in its own and world recognised and a concern of WHO, whereas the atypicals are a different group. So bacteria are in, like, they can be subspecies, can be different groups, although it's the same genus. So the atypicals are not as a concerning disease process for a public health concern.
Right.
And that's why the TB is separate, because it's more for a public health concern, whereas the non-tuberculosis mycobacteria are not generally of public health concern.
In terms of its prevalence, i.e. how often you see it, would you put it in the box of normal or unusual?
Oh, unusual.
Thank you. I probably have asked you this question in a slightly different way already, but just bear with me. If you get a sample from a patient, it comes with a unique identification number related to that patient. If you get a sample from somewhere, it's not a sample from a patient, it's a sample from somewhere in the environment. It comes, I'm told, with something called a ZM number. Can you ever remember getting Mycobacterium chelonae associated with a ZM number?
I personally didn't work with any of the environmental samples. It's part of my remit. So I didn't look at or authorise any environmental samples. I was aware, just through discussion with my consultant, that there was water samples and they were looking for Mycobacterium chelonae, but I had no input into the processing of the samples.
I'm going to move on now to deal with a number of meetings that you attended for the reasons that you've explained to us earlier. Could we go to 116, page 116 of your witness statement? This is an IMT. I'm not going to dig out the minutes at the moment. But I see in your witness statement, you pick up the fact that you said that the Aspergillus was attributed toward 2A. And then in paragraph 149, you're dealing with, I think, a subtlety which may easily elude the lay people in the room, that you've got a positive test for Aspergillus, aspergillosis, I think. And then you say, well, if you want to go from probable, which is what one test gives you, to proven, you need a second test. Am I picking that up correctly?
Not really. What the criteria for the EROTC guidelines for fungal disease, so it's invasive fungal disease, IFD, is that the definition of a possible infection, it requires, the guidelines require 2 positive Aspergillus PCRs, 2 consecutive samples. So that's what I'm referring to there. They would need a second Aspergillus PCR. There is other tests that are included in the definition of a probable infection, but the second Aspergillus PCR would still make it probable. It needs the second one to make it probable, yes.
Thank you. I think the other point that you pick up from this meeting is the prescribing of prophylaxis, not for ordinary clinical reasons, but because there was a risk of fungal infection. Is that the point that you're trying to make here?
Yes, they are wanting to look at prophylaxis for the patients to prevent fungal infections. So some antifungal drugs are used for both prophylaxis and treatment, given at a different dose. So you can use the same agent or the same antifungal, but prescribe it differently. It is recognised that some antifungals can be used as prophylactic agents to prevent the fungal infection. Then it can be used at a different dose as a treatment option.
you. Well, let's move on to the next meeting in the sequence, which appears on page 118. Again, the topic seems to be Aspergillus. And you explain a number of the ways in which you can diagnose Aspergillus, is that right?
Yes.
But you weren't really providing any guidance at this stage in that meeting.
No, my remit there was just the results and the test results of the patients who had been discussed at the IMT who had Aspergillus. So I was just there to go over the test results. I didn't give any advice on treatment or prophylaxis.
And just so we perhaps pick up one or two of the phrases used in paragraph 156, you talk about the IMT raising it with Public Health Scotland. Could that be HPS we're referring to there?
Yes.
And then in 159, we're talking about public health offering a view. Would I be right in thinking that was the board's public health team that were commenting there?
Yes, it's sort of, just trying to read it. Yes, it was to do with what we've really discussed earlier about what we perceive, as I said, as from microbiology and what we're seeing in our results and what public health see from the results.
Yeah.
Because they may just have one patient being discussed or two patients at the IMT, but we are seeing more patients.
So you've got the sort of overview of all the testing.
Yes.
Thank you. On page 120, we pick up another meeting. We're in December 17, and you say you can recall this one because there was a problem in PICU with Acinetobacter.
Yes.
Right? And you introduce another acronym here, PFGE, and I understand that that's a form of test associated with DNA.
That's correct, yes.
And it's different from whole genome sequencing, is it?
Yes. So, would you like me to explain?
Well, just briefly, please.
Yeah. Okay, so again, just refer to this Acinetobacter. Again, it's because it was an alert organism now. As you can see, it's December 2017. So this is one of the organisms that now we have to investigate if there's an increased number of cases. So to try and show that there was a cluster or there was movement of the organism between patient to patient, you need to show that it's the same strain. Now we're talking about genus and species, so we can say it's an Acinetobacter, we can say it's Burmannii, but within each species and genus, down to species level, there's subvariants of that species.
Yes.
So to show if it's the same subvariant of the species, we have different technology. We, in microbiology at QH, don't have this technology. So we rely on the reference labs to do this for us. In this situation, it was Health Protection England, which is now, as you know, been renamed as UK HSA. The isolates were sent for the pulse field gel exophasis. So that is when the organism is put on a gel, a matrix with an electric current, and it pulls out the bands of the DNA. So you get a pattern of banding, which looks at the DNA. Whole gene sequencing, which has now been introduced into the reference labs to allow us to look at outbreaks of organisms. For example, like we have an E. coli 157 outbreak or a salmonella outbreak. They can go detailed level of the DNA of the organism. So it's looking at the genome or the DNA of the bacteria to find out that it's the same, and then maybe find the source or the common source of the organism. So what we're saying here was that the whole gene sequencing was finding a match. They were finding that they were the same at that level. the pulse field gel electrophoresis was showing that they were the same. And what Professor Leonard said, that he wanted more detailed testing to even further investigate the organism to see if it was similar by the DNA.
So a sample had gone away to a reference lab. The reference lab used the test it used. And I think you say elsewhere in your statement, which was the test which was usually accepted by infection control teams.
Yes.
But Professor Leonard wasn't happy with that and wanted whole genome sequencing done.
Yes.
There are one other issue that crops up in that meeting is covered by you in paragraph 168. Now, what you say here is that Professor Leonard says the background rate of Acinetobacter has not changed when compared to previous years. Your comment is, well, it shouldn't be there at all.
Yes.
I mean, is that what I'm picking up from that statement?
Yeah, I mean, there may have been, cases from time to time, but I don't think it's acceptable to have a background rate of an organism. And again, referring to Appendix 13, it's one of the organisms that's now an alert organism. So even, 2 cases should be an alert. So if you're having an IMT, which is correct, we should be doing that. But what I'm trying to say is, well, we're having an IMT that we think there's a cluster, there has been some isolates found to be the same. But then they're saying that there's a background rate.
I think you're saying 169, there were 7 cases being discussed, is that right?
Yes, and then on the next minutes, there's another, I can't remember my notes, there's another 6 cases, I think there's 13 altogether. So there's a further IMT because the cases are continuing, where we're seeing more of them. So there's a further IMT with more cases later, I think 6 months later.
The other thing that runs through these minutes, and it may not matter for our purposes, is some sinks that were supposed to be taken out and were still there months later. Is that right?
Yes, because I visited PICU most days, nearly every day. And these big trough sinks were sitting in the middle of the ward, and they were being inappropriately used. They were putting, as Fathom walked the sluice room, they were putting like waste and I think down, and they shouldn't really have, I don't know why they were there, and the consultants in PICU were also wanting them moved. And it was minuted in 2 or 3 minutes that would be a corrective action to move the sinks. And it hadn't been done. And then a further minute, which is in my bundle, it said that they couldn't do it at that time. So they were thought to be a possible source. So the hypothesis at the end of an IMT is where your source is from, what the corrective actions are. And this was a possible corrective action to remove the sinks, because it could have been a source of the Acinetobacter infection.
I think the point you made about more cases, I think that emerges on the next page of your statement when you pick up an IMT of the 6th of June 2018 relating to an increase in this organism, and you point out here there are another 6. So something is still going on somewhere.
Yes.
And we pick up the point about sinks. I just want to pick up the next meeting. Can we have bundle 1343, please? A couple of reasons for going here. Firstly, because this is the 14th August 2019 meeting that when you originally wrote your statement, you couldn't remember the date of and have subsequently
That's correct.
remembered. First thing perhaps notable about this meeting is there's a cast of thousands at this one. a very large number of people.
Yes.
Do you know why there was so many people there? This huge
I
gathering.
think the fact that there was the number of patients, so that there was 11 of these patients, and this was after this was the move to, the patients were, to contact were in 6A. They had been moved out the Schehallien ward at this time, and the infections were still happening. So there was concern that even though the CLAPSI group were doing really well with the line care and management of lines and procedures, the infections were still happening. So there was a lot of people involved, from infection control, from the clinicians to management, clinical directors. And I was asked
This
to come.
is one I think you were at because Teresa Inkster had asked you to go.
Yes, that's correct.
And you had a particular interest in the paediatric intensive care unit, which was part of the...
This particular minute is the paediatric hematology oncology unit. Right. The previous ones, the Acinetobacter, they were, yes, I was involved, but also there were some of these children were in PICU. So that's also, so I crossed over from the previous minutes were Acinetobacter and PICU. These were hematology oncology patients, but they were also in PICU because they were very unwell, and that was another concern, that they were, their condition was of a concern because of the sepsis with the environmental gram negatives in their lines. So some of them had to require intensive care and also line removal. So I think I can have covered sort of both areas in that respect with this minute.
Can we go on to the next page of the minute, please? And you reference in your witness statement the comment about halfway down the page after the section of redaction. Chris Deegan, that's someone you hadn't really had much contact with, as I understand from your statement. Is that correct?
Yes.
Pointed out numbers of bacteria have not increased and reference an epidemiology report by Dr. Kennedy, which you haven't seen. Is that right?
Yes.
And this was in response to a comment from one of the consultants, that's presumably a clinical consultant, who said there'd been an increase in infections. And it notes here, Dr. Inkster and Dr. Peter stated the nature of the bacteria was a concern. Dr. Inkster stated we're not seeing typical pathogens for these patient group, and then gives some examples. It's likely that the good work of the line team has driven that down. Organisms we're seeing are environmental in nature and associated with water and soil. Now, when that's recorded as what Dr. Inkster says, do you agree with that?
Yes.
And the Dr. Kennedy that's mentioned, he's the individual from the board's public health team, although I think in your statement you sometimes call him Public Health Scotland.
Yes, the terminology changed.
Thank you.
You say the terminology has changed, and you're right about that, but I am right in thinking that Dr. Kennedy is a GGC public health consultant. Yes. Yeah.
If we just go, I'm just jumping between the minute, but let's leave the minute on the screen for the moment. In your witness statement, paragraph 179, you record that Drs. Inkster and Peter said there was a concern that the organisms were environmental. And you record this as one of the meetings where corporate management, and it probably won't be HPS, it'll be Dr. Kennedy, were saying that what we were seeing was normal. Can I just pause there and ask, did you agree that what you were seeing was normal?
No.
And this goes back to the presentation.
Yes.
That you say you've referenced again. So when Drs. Inkster and Peters are raising these concerns in the course of this meeting, are you agreeing with them or are you disagreeing with them?
I'm agreeing with both Christine and Teresa.
Thank you. Well, we can leave that minute. Thank you. I've just like the technical question to ask you, if we go back to the witness statement 127, please. In paragraph 183, you record a request by HPS for data, which you seem to be a little taken aback by and had to refer up to Christine Peters. Is that right?
Yes.
When HPS were in touch, did they not make it clear that they knew you'd need to get some kind of consent before you released data?
No, I was emailed asking for my results, and there was no CC into my line manager, my clinical lead. It was directly to me. And I wasn't going to give patient information outside the organisation or outside of the laboratory without going through my line manager. So we would never give results out or data out without having it cleared or agreed with a senior member of our management staff. So the first thing I did was forward the email to Christine Peter, her information and her comments, and she responded to that email.
Thank you. Okay, we'll move on to the next meeting, if we may, which was a meeting, an IMT on the 6th of September 2019 about gram-negative bacteria. Now, if I just take it generally, first of all, I think one of the points you're making about this meeting is that you didn't think the minutes recorded accurately everything that you noted as having happened. Is that right?
That's correct.
So that we see this, for instance, at paragraph 185, where about 2/3 of the way down, Tom Steele is saying, no, there's no leaking. If there's a leak, it would have been hot water and it would evaporate. Dr. Crichton says something about chilled beams being acceptable in the hospital. And then you say you had notes taken at the meeting, and when did you make these notes? Actually, at the time?
Yes, I had pen and paper with me, and I took all the notes down, because at this meeting, as you can see, Christine Peters and Teresa Inkster were not invited. So Teresa asked me to go on her behalf and to represent microbiology along with Dr. Valaraki Pepe. She came too as infection control representation from microbiology. She was the consultant microbiology and infection control. So her and myself went along to this meeting, and I was asked to take notes. And after the meeting, I typed up the notes, a brief summary of the notes, and I emailed it to all the microbiology consultants in the department.
So the point you're making at the foot of, or near the foot of page 128, is that your note says that at the meeting it was said that 2 times in the same month the boilers were down, temperature trends were monitored, boiler pressure was lost, and this caused increased, condensation leaks from chill beams associated with the duration of boiler failure. And that's what you recollect having been discussed.
Yes, I wrote it down, and I've got it typed in my debrief notes from the minutes of my minutes, but it wasn't included in the actual minutes of the meeting by the minute taker.
And then you record Pepe Valaraki saying to Mr. Steele, well, Christine Peters has got pictures of them leaking.
Yes.
And then you quote a comment about chilled beams, which I don't think we need worry about at the moment. And in fact, you make a comment that you've had water dripping from a chilled beam onto your head.
Yes, I have.
And we've heard from other witnesses about that there was an issue with the dew point control for condensation.
Yes.
Just bear with me a second. So at this point, were you comfortable that the minutes were recording everything that was said?
No. And further to that, at the next IMT, some of the minutes were removed. So they're not actually in the minutes.
So if we carry on to page 130 of your witness statement, you've discussed the relationship between York Hill and Great Ormond Street. I think you said York Hill was the Great Ormond Street of the North.
Yes.
Which is an interesting title. And that's why you ask about them. And I think you asked about whether Great Ormond Street had chill beams, to which the answer is apparently no. And there's a reference, I wasn't sure I fully understood, in page 130, paragraph 188. You say that from your notes, not recorded in the minutes, a review by Dr. Hartley from GOSH, who is a consultant microbiologist and director of infection control, to visit the hospital was planned. So that was something that cropped up at the meeting but wasn't in the minutes, is that right?
Because I wrote it down, and I do know Dr. Hartley. She's been in microbiology at York Hill. So we did really, before the move, when we were a paediatric standalone hospital and a standalone NHS trust, York Hill Trust, we did work closely with Great Ormond Street, and we would phone them for advice, because being a paediatric hospital and a paediatric microbiology department, Great Ormond Street also have their own microbiology department, which is specifically paediatrics. It's a standalone paediatric hospital. So we would refer to them some of the assays that they used. I got information. I'd been down to Great Ormond Street during my career. So, and I know the clinical scientists that work in Great Ormond Street. So they were a useful kind of comparator for us.
And can I just ask though, what is this review by Dr. Hartley that you've made a note about? Can you remember what it was meant to be?
Well, I think they wanted, just as I've said, a paediatric microbiologist, infection control doctor from another hospital, paediatric hospital, to visit and compare the issues that we were having and give advice. The minutes and the discussion around Dr. Hartley coming did not discuss the reason for her visit, but just said it would be a review and a visit to the hospital.
Did it happen, as far as you know?
As far as I'm aware, it did not happen, no.
And in 189, you pick up a point where Doctors Kennedy and Deegan are saying something about not recognising an increase, and apparently you said something that's not in the minutes about what you had found, is that right?
Yes.
And you said that the blood cultures are mixed polymicrobial and the diversity of the bacteria was different from York Hill.
Yes. I did say that.
Did you think you were being listened to?
I don't think they agreed with what I was saying.
So this is well on in the narrative now. We're now 2019 and you're still concerned.
Yes.
Is that correct?
Yes. And that's since 2016.
Thank you. But that's the only other document I wanted to put to you. In the remainder of your statement, you've picked up what you say are some of the impacts that you felt from this situation. If I can summarize it as I understand it, what you're saying is one of the challenges doing the job you did was that you saw the samples, you spoke to the clinicians, you were sometimes on the ward speaking to the clinicians, but you didn't have any direct contact with the patient, but nevertheless you knew what was happening to them. Is that fair?
Yes, from a clinical point of view, from speaking to the clinicians, I knew what their patient history was, what type of hematological disease they had, what their condition was relative to their treatment, where they were in their treatment, what the risks were of infection, how immunosuppressed they were, what antibiotics they were on, were they on the right antibiotics, what was the treatment plan. So I knew about the patient, but had no direct patient care in that respect.
But you still knew what was happening.
Yes.
I think you indicate that that concerned you, upset you, whatever phrase you want to pick.
Yes, it did, because these children were having to have their lines removed. And that meant a general anaesthetic. And they had to fast before that. And then the line had to be taken out and a new line put in. And with the increase in the infections, they were having more lines removed. And also some of them became quite unwell and had to go to PICU for care, supportive care in the intensive care unit. And that was upsetting for the children and for the families as well.
Did you get the impression before you retired that the role of pediatric clinical microbiologist was a role that the board were valuing?
No, I don't think so, because they were not replacing the clinical scientists who'd retired. And they weren't replacing or appointing a consultant microbiologist with specific pediatric experience. We did appoint a consultant from Alderhay, but he was only with us for 6 months, and at least 6 months, maybe 9 months, and he was really very, very informative. And, you know, I worked with him. Our offices were next door. But going forward after that, we don't have a consultant who has pediatric experience in their training. There was 2 consultant pediatric microbiologists. As you know, Professor Williams was clinical lead and microbiology consultant, and he moved on to another job, and he wasn't replaced. The other part-time clinician or consultant microbiologist, should I say, she's now retired as well. So the consultants in our microbiology department, I mean, they do pediatrics. They're on the rota. They have, you know, they're well equipped to do pediatrics, but we don't have specifically trained pediatric microbiologists.
And I think just as a tailpiece in your witness statement, you say you did think about going into the sort of whistleblowing process, but you decided not to do so.
Yeah, I did. I do know there was people in my department who were whistleblowers, and we were aware of the department that had happened. And at the time, I wasn't sure what to do, and I didn't want to affect my career. And so really why I'm here today is because I was asked to be a witness in the public inquiry and to provide a statement. So I thought, well, that's my way of letting people know how I felt and what was happening in the hospital, rather than whistleblowing. So it's my opportunity to tell you how I felt about what was happening, rather than doing the whistleblowing.
I have no further questions for this witness, my lord.
Well, Ms. Harvey-Woods, what I need to do is discover whether there are any other questions in the room. And so what we'll do is we'll take a break of about 10 minutes or so, and we'll find out if there are any other questions. And I would hope to be able to call you back then, and we'll find out what the situation is. But can I ask you to go back to the witness room, if you could?
Thank you.
Now, Mr. Connell?
Yes, but Lord, I have one question I've been asked to put to the witness. Just before I ask for her to be brought back, I've just been asked to clarify that, of course, the only Mukherjee report prepared that has any relevance to this inquiry was, of course, a report instructed by this inquiry and is not a board document in any way. And I think some confusion may have arisen as to how we touched on that, but I've been asked to clarify that.
Well, it may be something that's arisen from my intervention, because what I thought the witness was referring to, or about to refer to, was something which is not in the inquiry bundle. Now, Mr. Mukherjee's report is in the inquiry bundle, and as you correctly say, Mr. Mukherjee's report was instructed on behalf of the inquiry. Now, do you feel that?
No, that I'm sure it's satisfactory. I wouldn't seek to ask this witness questions about Mr. Mukherjee's report in any event.
No.
So I have only a single question for the witness.
Now, does that? I'm just wondering if I'm picking up the body language in the room correctly. Mr. Love, does that? I was satisfied. Right. Thank you. Yep. Perhaps just one matter, okay. Ms. Harvey-Wood.
Just a question that arises from something you said right at the end of your evidence that I've been asked to clarify with you. When I asked you about the fact that you thought about whistleblowing but decided not to and decided to take this opportunity of telling your story, you made a comment about possibly affecting your career. What did you mean by that?
I just meant that I didn't want to have any kind of, how do I put this, effect on me personally from my ability to do my job. And it was towards the end of my career and I wanted to continue in my job. And I didn't want to have any, this is very difficult for me, any kind of negative feedback or anything, because I think whistleblowing is quite a complex and quite an onerous thing to do, and you really have to put a lot of time and effort into your whistleblowing statement and have enough evidence to support whistleblowing. So at my level of, as a clinical scientist, I'm not a clinician, I wouldn't have the GMC, support, and I felt that because my line manager was whistleblowing, in that respect, then maybe it wasn't necessary for me to do it as well.
Thank you very much. I have no further questions, my Lord.
Thank you very much, Ms. Harvey-Woods. Thank you for your attendance today and answering Mr. Connell's questions. But thank you also for the work you've done in preparing your witness statement. I think, as you referred earlier in your evidence, you've maybe had to look at, go back over that work on more than one occasion. I appreciate that will have been quite onerous. So thank you not only for your attendance today and your evidence today, but also the important part of the evidence of the inquiry, which is represented by your statement. So thank you for both, but you're now free to go.
Thank you. Thank you, Lord.
Now, my understanding, Mr. Connell, is that we have not been able to schedule a witness for this afternoon.
That is correct, my Lord. A witness who was scheduled for today wasn't going to be available today for a variety of reasons.
But we will be able to resume tomorrow at 10. Very well. Can I wish you a good afternoon, and all being well, we'll see each other tomorrow at 10.